Adolescents with severe obesity face significant health challenges, but a recent study offers new hope. Published in JAMA Pediatrics, the study reveals that combining meal replacement therapy with financial incentives leads to a greater reduction in body mass index, or BMI, compared to meal replacement therapy alone. Severe obesity affects about 1 in 5 children and adolescents in the United States, according to the Centers for Disease Control and Prevention. Defined as having a BMI at or above the 95th percentile for age and sex, severe obesity is linked to increased risks of adult obesity, cardiovascular disease, type 2 diabetes, and other conditions. Traditional lifestyle modifications often fall short in addressing this issue, prompting researchers to explore more effective interventions. The study, co-authored by Justin Ryder, Ph.D., Vice Chair of Research for the Department of Surgery at Ann and Robert H. Lurie Children's Hospital of Chicago, aimed to determine if adding financial incentives to meal replacement therapy would enhance its efficacy in reducing BMI among adolescents with severe obesity. Previous literature suggests that financial incentives can improve adherence to weight loss programs in adults, but this study sought to test the concept in adolescents. The study enrolled 126 adolescents with severe obesity, dividing them into 2 groups. One group received meal replacement therapy plus financial incentives, while the other group received only meal replacement therapy. The meal replacement therapy consisted of pre-portioned meals totaling 1,200 calories per day. Financial incentives were provided based on the reduction in body weight from baseline. Over the course of 1 year, researchers monitored the participants to evaluate the effectiveness of the interventions. After 52 weeks, the group that received meal replacement therapy plus financial incentives showed a greater reduction in BMI, with a decrease of 6 percentage points, compared to the group that received only meal replacement therapy. Additionally, the financial incentives group experienced a greater reduction in total body fat mass, losing an average of 4.8 kilograms. There's literature for adults that supports that tying in financial incentives to weight loss or physical activity programs increases adherence, said Dr. Ryder. This study confirms that the same approach can be effective for adolescents. The researchers also conducted a cost-effectiveness analysis, comparing the mean fat mass loss between the 2 treatments. Despite the additional cost of providing meal replacements, the analysis found that it was cost-effective to combine meal replacement therapy with financial incentives. Using a cost-effectiveness analysis, we looked at mean fat mass lost between the 2 treatments and found that despite providing the additional meal replacements for per pound lost, it was cost-effective to do so, Dr. Ryder added. While the study's findings are promising, the authors emphasize the need for further research to develop long-term interventions. While financial incentives plus MRT appears to be a longer-term strategy than MRT alone, treatment withdrawal will likely result in BMI increase. As such, research is needed to identify strategies that are scalable and feasible in the long term, given the chronic nature of obesity, the authors wrote. This work was supported by grants from the National Institute of Diabetes and Digestive and Kidney Diseases and the National Institutes of Health National Center for Advancing Translational Sciences. Healthy for Life Meals also provided financial assistance with the meal program. By exploring innovative approaches like combining meal replacement therapy with financial incentives, researchers are paving the way for more effective treatments for severe obesity in adolescents.